Today, the meeting is the topic is metastasis. The history: Mr. S, 44-year-old male carpenter from Bellur. He presented to emergency department with the complaints of fever for 4 days, with the right upper quadrant pain for 3 days and lower limb swelling for 3 days. So the fever was a high-grade fever, which was intermittent with evening rise, which was associated with chills and rigors. And right upper quadrant pain, which was acute on onset. It was not radiating and stabbing type of pain. There was no history of cough, bloody diarrhea, or loose stools. Past medical history: he is a man diagnosed with diabetes mellitus 8 years ago, was on insulin and OHS with a poor complaints, and there was no history of hypertension or no abdominal surgery or trauma previously. And a personal medical history: ethanol consumer for 15 years. On examination, he is conscious, cooperative, he is obeying commands. There was a diffuse muscle wasting on bilateral upper and lower limbs. And vitals wise, heart rate of 106 with the blood pressure of 110/60 on with noradrenaline of 10 mic supports. The respiratory rate of 22 on presentation, saturating 99% on room air. On examination, his peripheries were warm. There was no pallor, icterus, clubbing, cyanosis, or lymphadenopathy. Bilateral pedal edema was there up to the knee. CVS cardiovascular examination, S1, S2 had no murmurs. Abdominal examination, there was a right upper quadrant tenderness. There was a shifting dullness present, and bowel sounds were present normally. Respiratory examination, the clear vesicular breath sounds, no added sounds, no adventitious sounds. Bilateral air entry was there. CNS examination, no focal neurological deficit. There was no flaps. Fundus examination, there was a retinopathy changes present. Initial differentials on the fever with right upper quadrant pain with a warm shock was considered as a abscess with bacteremia, cholangitis with septicemia, bacteremia, and cholecystitis, right lower lobe pneumonia, colitis, and investigation wise. CBC was done. It shows the HP of 8.7 with the 81 of MCV with the total counts of 17,100 with the neutrophil predominance. Platelets of 56,000. LFT was, it shows the hypoalbuminemia of 1.9 with elevated alkaline phosphatase. RFT was normal. Serum electrolyte shows hyponatremia. Clinically, he was hypervolemic. Calcium phosphorus was done. It shows a corrected calcium of 9.6. Procalcitonin was done, was 35. HbA1c was 11.1, suggestive of uncontrolled diabetes mellitus. And PT-INR was done. It was deranged. It shows the coagulopathy. And APTT was 40.1. So this is a man with a fever with right upper quadrant pain and shock was started with antibiotics. Blood cultures were taken before that. Blood culture grown and Klebsiella pneumonia, pan sensitive on the second day of hospital stay. So on examination, there was a right upper quadrant. So imaging was done. Imaging was done, shows the multiple liver abscess that present. And he was started with the antibiotics. He was fine for first 4 days during the hospital stay. He was responding well. Inotropes were slowly tapered and stopped. He was afebrile. And on 4th day of admission, he started developing a breathing difficulty. He was desaturated to 86% on room air. So on examination, auscultation was done. That shows the decreased breath sounds on the right side compared with the left side. And on the percussion, there was a dullness noted. And imaging was done at that time. That shows us the new onset pleural effusion. The first X-ray was the admission X-ray, and after 4 days, this is the X-ray taken during the time of breathing difficulty. So there was a massive pleural effusion. That was the diagnostic tap was done. That shows the exudative, and culture was sent from the pleural effusion. That also grown a Klebsiella pneumonia, which was also pan sensitive. And the final diagnosis we have is Klebsiella, invasive liver abscess Klebsiella that associated with bacteremia and metastasis to the lungs and blood. So we did in view of a hypervirulent strain, we did a hypervirulent test for the Klebsiella that came positive for RMPA and RMPA2 and IUCA, that's suggestive of hypervirulent strain of Klebsiella. So here I'm talking about the hypervirulent strain of Klebsiella that causing the community occurred liver abscess with the possible metastasis to the lungs and the blood. So Klebsiella pneumonia can produce an infection at various sites with the risk being increased in patients and the impaired host defenses, as our patient had uncontrolled diabetes mellitus and alcoholism, and occurs in the absence of any intra-abdominal factors. And the chronic COPD and glucocorticoid therapies are other risk factors for the invasive liver abscess secondary to Klebsiella. Most common clinical presentation is the fever, followed by right upper quadrant tenderness and nausea, vomiting. Leukocytosis will be there with the elevation of alkaline phosphatase and AST, ALT. Hypervirulent Klebsiella, before it was a rare variant. Now it is very common among South Asian and mostly in a South Indian population also. So Klebsiella pneumonia is an increasingly important bacterial pathogen that is capable of causing severe organ and life-threatening disease. So incidence steadily increasing over last 3 years in the South Asian and the South Indian community, mostly causing community-acquired liver abscess. Most of the patient with the community-acquired liver abscess, Klebsiella is the most common cause nowadays, compared with the nosocomial causes of Klebsiella. And the hypervirulent Klebsiella is the most common cause among them. So metastatic infection, this hypervirulent Klebsiella can possibly causes metastatic infection in various parts of the body. The predisposing factors, whenever the patient is having a thrombophlebitis of portal vein and a hepatic venous system, predisposes to the metastatic infection. Endophthalmitis is possible, meningitis is possible, brain abscess are also common. Lung abscess, psoas, splenic abscess, osteomyelitis are possible in the condition. Pulmonary septic embolia is common with the unilocular abscesses secondary to hypervirulent Klebsiella. Septic pulmonary embolia were associated with the unilocular abscess. There are some studies that shows hypervirulent Klebsiella with the initial presentation with the liver abscess can go to the multiple areas and causing metastatic lesions. And these are the pathotypes of hypervirulent Klebsiella pneumonia. The classical hypervirulent Klebsiella pneumonia is a hypermucoviscous. That is what in our patient, and our patient is having a classical hypervirulent Klebsiella with RMPA and RMPA2 positive with IUCA present with the string test positive. There are other variants of hypervirulent Klebsiella nowadays are emerging with the string test negative Klebsiella also. Initially, our microbiology is doing the string test, followed by that they are doing the PCR to divide the Klebsiella into the different variants. And in our patients, string test was positive, and multiplex PCR was done for the hypervirulent Klebsiella also came as positive. The other variants are multi-drug resistant hypervirulent Klebsiella with the string positive and the multi-drug resistant hypervirulent Klebsiella with the string negative. Some of the nowadays some of the Klebsiellas are hypervirulent Klebsiellas are string negatives, but with the help of multiplex PCR, they are diagnosed as a hypervirulent. So some of the virulence factor that causes the hypervirulency in the Klebsiella are capsules, hypermucosity phenotype, lipopolysaccharides, and siderophores and the fimbriae. Hypomucosity phenotype is the most common thing that causes the Klebsiella to be more hypervirulent. And this is the classical versus hypervirulent Klebsiella pneumonia. Hypervirulent Klebsiella pneumonia is more commonly in the community nowadays rather than the classical pneumonia. Classical pneumonia is more of a nosocomial infection in the hospital acute settings. Hosts are most of the hypervirulent Klebsiella patient with all ages of an otherwise healthy patient. In a classical Klebsiella will mostly come in the older patient with a very poor immunocompromised state. And mostly hypervirulent is now developing, growing in the South Asian population mostly. And the hepatic abscess usually occurs in the absence of biliary disease. And number of sites of infections are hypervirulent Klebsiella is often multiple, and classical Klebsiella is mostly present on the single site. And usually metastases are mostly related with the hypervirulent Klebsiella. And the treatment for the hypervirulent Klebsiella with the liver abscess, what we did in our patient is most of the hypervirulent Klebsiella related liver abscess are very solidified. So it's very, it will take long time for the liquefaction. So, but percutaneous drainage is a treatment that we can try. But in our patient, we tried, it was not possible to aspirate because of the solidification. So we were asking the patient to come in the OPD to follow up how was whether the abscess is getting liquefied or not. And the second options are the antibiotics. So we are planned for the 4 to 6 weeks of antibiotic course, for 2 weeks of IV antibiotic and 4 weeks of oral antibiotics. Initially, he was started with the empirical meropenem. Then after the sensitivity, it was downgraded to the piperacillin. Then we will send him with the oral antibiotic of levofloxacin since the Klebsiella was sensitive to levofloxacin. So prevention and prognosis in these conditions are patient with uncontrolled diabetes mellitus. They are prone for a hyperurulent Klebsiella in nowadays in a community acquired infection, and the usage of certain drugs shows low risk of Klebsiella. Some of the studies that shows us aspirin, metformin, histamine blockers, and proton pump inhibitors are showing some of the benefit against the hyperurulent Klebsiella in a community basis, but the studies are not yet completed. And a patient with metastatic infection shows the poor prognosis. Most of the patient with the meningitis and endophthalmitis shows the poor prognosis, but many patients with the metastatic infection died of septicemia. 11 to 13% of mortality with the metastatic infection, mostly due to septicemia. So learning points are Klebsiella liver abscess from the community without any hepatobiliary predisposing factors can be possible with the hypervirulent Klebsiella pneumonia. Timely management with the antibiotics and continuous course of antibiotics will help the patient.
Thank you, Brightus. Any questions or comments? So in your case, was the strain hypermucoviscoid as well?
Yes, sir. Hypermucoviscoid.
The strain test was positive.
Yes, sir. Yeah.
If there are no further questions, we will call it a day. I think there were two presentations which were quite good in terms of the way it was presented. Dr. Pranuth and Dr.